Hello, everyone. Today, we're going to be talking about the lessons that we've been learning to increase young men's engagement in HIV and sexual and reproductive health services in Zimbabwe. So we know that youth are underserved by existing sexual and reproductive health structures. And over the last 10 years, concerted efforts have been made to address the high risks that adolescent girls and young women face. And in doing so, an argument has been made that young men have been left out, and this has undermined our abilities to improve youth outcomes. So in today's presentation, I discuss how a community-based HIV and SRH intervention in Zimbabwe is adapting and refining its implementation to address this gap locally through designing an intervention that young men will want to access. So the CHIEDZA trial began in April 2019 in Zimbabwe. This is a cluster randomized trial that is a community-based intervention offering HIV and sexual and reproductive health services for youth aged 16 to 24. This package includes HIV testing and counseling. For those who test positive, it includes linkage to care. It includes HIV care and treatment, as well as adherence support. The SRH package includes family planning services and support, menstrual health products and support, STI testing, treatment, and support, as well as condom distribution. And we also offer general health counseling for young people who might want to come in and talk to us about whatever issues they might be having. And from its very inception, one of the key aims of CHIEDZA was to really address this gap in young men's uptake and engagement in HIV and sexual and reproductive health services. So in this presentation, I'm really going to talk about what it's going to take to increase young men's engagement in SRH services. So the findings that we'll be talking about today come from 4 primary data sources. We have our routine quantitative data on services uptake within CHIEDZA, and then the qualitative data includes non-participant observations at the CHIEDZA sites. We had participant observations and notes from team meetings between the research and implementation team. And then we had interviews with the providers as well as the youth clients. And interviews with the youth clients actually included the young men themselves. And so, like I mentioned, from the very beginning, engaging with young men was a concern that CHIEDZA was aware of and wanted to address. So we co-designed the CHIEDZA intervention with young men from the intervention communities so that we could create an intervention that has an ethos and an approach that will be appealing to young men. So CHIEDZA, when it was designed to include social activities like soccer, playing pool, playing darts, music, and television. It was designed to include peer-to-peer mobilization, so young men could go out into the CHIEDZA communities to talk to their peers about what CHIEDZA has to offer. We have the reliable, free, and available services that I talked about in the introduction, as well as our youth-friendly and non-judgmental trained providers offering these services. However, despite this design, this approach, we still realize that from our quantitative programmatic data, the attendance remained skewed by gender at 1 male is to 3 females. So we decided to explore qualitatively why we were seeing this skew and this difference in males to females attending CHIEDZA. And we saw that despite branding CHIEDZA as a space that is accessible to all young people, including those who are healthy, young men continued to only want to access health services when they're symptomatically sick. And they had an incredible fear of engaging with HIV testing. And you can see that from some of the quotes that are present in this slide particularly. We also saw that young men had fewer take-home commodities. So young men could only take home condoms, whereas young women could take home menstrual health products. They could take home contraceptive commodities, and then they could also take home condoms like their male peers. And then young men also had reluctance to spend the day waiting in line, and even just traveling from the CHIEDZA community centers, from the CHIEDZA communities to the centers, they were not willing to do that. And then with COVID-19, we had to also stop the social activities that had been very appealing when we designed the CHIEDZA intervention itself. So in response to these barriers that they told us, we adapted the intervention, right? So we started to offer free transport, COVID restrictions allowing, from the communities to the CHIEDZA centers. They have reduced waiting time. When they get to CHIEDZA, they actually don't have to wait in line. And then as of 8 weeks ago, we increased the range of take-home commodities. So young men can now get a voucher to the local barber to get their hair cut. And then they also have quality underwear. And this was after we'd engaged with young men about what it might take to actually improve their engagement. However, despite the fact that we would see spikes in absolute numbers of new male clients attending CHIEDZA every time we would introduce some of these adaptations, the overall ratio of 1:3 remained pretty consistent. So this then started to tell us that responsibly adapting service provision and incentives might actually be inadequate to engaging young men in HIV and sexual and reproductive health services. So beyond health-related barriers and enablers, young men consistently told us that they wanted health services that offer opportunities for social interaction, income generation, and vocational training, right? To us, they told us that their concerns are less health-related and are more centered around building social capital and generating income, things that were seen as instrumental to attaining adult masculine attributes. So with all of this going on and adapting and implementing things that young men told us they wanted to improve engagement, what are the insights that we learned from this, right? And we've learned that youth have gendered health priorities and require different incentives to engage with healthcare. So for us implementers, there needs to be consideration for gender tensions that may arise when we're curating and adapting interventions. We've seen that this responsive trial model that CHIEDZA has been implementing is good. There are benefits to it, right? Because we meaningfully integrate feedback and adapt interventions for young people that ordinarily have low rates of engagement. However, with the CHIEDZA example, we saw that our ratio still remained at 1:3. So there remain some questions that we can all think about and ponder through. For example, how can we better engage young men to health services beyond health-related priorities, which engage in structural drivers of gendered risk? Is there an opportunity here for us to develop an integrated model that is at the intersection of health, education, and income generation to better improve young men's engagement in sexual and reproductive health services? How can mechanisms be developed that allow funders and donors to actually support a trial, a program, an intervention that explores this kind of intersectoral integrated approach to support sustained improvements in SRH outcomes for both young men and young women? We didn't have the solution in CHIEDZA, but we will leave you with these questions to think and ponder about. Thank you.